Okay, so it's 1 o'clock, and I think all our speakers are here, so we'll kick off with this week's Grand Rounds. Thanks very much to all 76 of you who are here just now. My name's Tom Farden, and I'm the chair and organiser of Grand Rounds in coordination with the NHS Tayside and the University of Dundee under the banner of the Academic Health Science Partnership here in Tayside. So Grand Rounds aims to be informative, entertaining, educational, and try to keep up to date with current scientific developments, but also taking in updates in the current social climate. And I think it's only appropriate and entirely right that we dedicate our Grand Round this week to speaking about the Black Lives Matter movement. And I'm very pleased that 3 of our medical students approached me independently to ask if they could have a slot at Grand Rounds to talk about these issues. I'm pleased that Rory McCrimmon is here he's the Dean of the Medical School, and we have representation from NES as well as colleagues from primary and secondary care. This is aimed as to start a discussion, which I think is an important discussion to have, and I'm really looking forward to hearing what the students have got to say. Now, before that, we're going to kick off with an operational update. Colin Fleming can't be here today, so he's left it with me. So we'll just lead straight on to Chris Schofield, who's clinical director for one of the medical clinical care groups, who is hopefully going to share his screen now, unmute himself, and give us an update in the operational update, followed by Alison Clement, who's one of the associate medical directors for the Angus Health and Social Care Partnership. All a bit of a mouthful. Chris, are you there?
I am. Can you see my screen?
I can see your screen. I can see your face. I can hear your voice. Let's
Wonderful.
Go.
Good. So thanks, Tom, and everyone for inviting me to speak about the primary and secondary care interface. Now, this was reportedly in the time of COVID, but I think actually, if we look back, we've been doing this for quite a bit longer than that. So thinking about an interface, it's a point where 2 systems meet and interact. I think that's completely incorrect. We're not 2 systems. To think we are is a problem. Status quo, remember, is not an aspiration. It's a band, and we need to start getting past the idea that the interface is something we want to perpetuate. From the point of view of chronic disease, which is where I sit, the way that usually works is you see your GP for diagnosis and initial management, and at some point you end up with a referral according to whatever defined criteria are agreed between GP and between primary care and secondary care. You get your initial appointment for your initial assessment, and then you go in this everlasting loop of 6 to 12 monthly routine appointments. Very rarely do you get cured, or there's a change of agreement and patients get discharged. Okay? Now that's okay potentially for one chronic disease, but think about your patient who's multimorbid. They've got diabetes, they've got heart failure, they've got fatty liver disease, they've got cardiovascular risk. They go to the sleep clinic, they get physio because they got bad knees because they're overweight. They're going to 6 of these clinics all at once. And we used to think that was a good way of dealing with things. So in diabetes, quite some time ago, we actually spoke to people and asked them what they thought about their experience. So this is an example patient who we interviewed, not his real name. He does like coming to clinic because it's a good chat. He enjoys his chat with people. What he dislikes is getting the bus in, dislikes multiple hospital trips because he goes to 3 or 4 clinics. And of course, being 76 with a 76-year-old wife, she goes to 3 hospital clinics as well. He doesn't understand why, if he had blood tests 3 days ago, why he has to have them again when he comes back to see somebody else for something slightly different. And the most important thing he said to me was, as long as I get seen and I get looked after, I don't care where this happens. So as I said, the interface is a false division. It's not 2 systems. We're a continuum of healthcare. So what are our options? Our options are to do nothing at all. And, high footfall, multiple low-value appointments and long waiting lists can persist forever. Or we can aim for something completely different, where we have low footfall, which we are hopefully expecting in the time of COVID to try and prevent cross-contamination and cross-infection. we can have a smaller number of very high value appointments. And when we need to be seen, or when patients need to be seen, we can give them minimal wait. So I've been working for some time now with Mark Jacobs and Nico Grunenberg in Angus, where I do my diabetes clinic. And they've been instrumental in helping me understand what happens in primary care and certainly moving things forward. We looked at our model of diabetes care. Our patient attended defined time at the request of NHS Tayside, not necessarily when was convenient to them. They came to see us. They had their blood tests performed and their venous bloods for routine screening. We then had a consultation during which we didn't have all the information that we would need to discuss all their problems and make decisions. And then sometime later, when we verify a letter, we review the results and we write to the patient, the GP, with recommendations that we potentially haven't discussed. So they agreed to do something different. We moved the blood tests to be performed in primary care. They were happy to do that. The patient attended the clinic. We then discussed with full information sharing using our online database and no physical notes. And we had a real-time clinic admin with a review of results of the patient. We discussed issues and recommendations, and we agreed a written plan, which we sent to the patient, and the GP was copied in. This has added advantages. It's 45 minutes per person more time efficient than the traditional clinic. And it's more than £30 per person less expensive to see somebody in that way. Okay? The proposed model, perhaps going forward, is that bloods are performed aligned to some recall system, and that could inform all chronic diseases which the patient suffers. We then have a multidisciplinary team review of results with shared decision-making, potentially multiple specialties, and the patient could be involved in that discussion, obviously. They're the most important person. We could use risk stratification. If the patient is completely stable, we may not need to see them, but we can let them know that everything is okay. And we can, again, have real-time decision-making. So why would we bother doing that? Well, it's more convenient. Some patients take a full day to come to clinic to see somebody. It's efficient because we reduce repetition of blood samples. It's patient-centered in the fact that it's locally delivered and it's timely. It's coordinated with the GP as the specialist generalist who's coordinating the care of this multimorbid patient. And it's needs-based so that patients can be seen quickly when they need to be seen. So the direction of travel that I see here is that the patient goes and they either attend for screening and risk stratification. They can self-refer, particularly in diabetes, if they've got their own problems and they want to discuss something. Or if the other healthcare worker has concerns, and then we can decide how best we deal with those problems between us. This led us to a conceptual design of what we call a spoke hub and node model for care of chronic disease in Tayside, and there's a primary care spoke, a specialist care node, but this idea is focused on this integrated community hub. Patients living with multiple stable comorbidities get their care delivered in an integrated healthcare environment with risk stratification and open, timely and accurate communication in conjunction with all key healthcare providers across the whole system. There are some barriers. IT is a barrier traditionally, but I am assured that things are changing. Specialty domains are something we need to think about. So patients with identified chronic diseases would need to be hosted in a virtual domain. So there's no discharge from the service unless there is the rare option of a cure. But that service is defined as all patients with chronic conditions, not just patients who are seen by secondary care. We need to have a rapid realignment of how we work, and acceptance from specialty colleagues that many skills are not unique to specialists. There are things that we can do that only our specialists can do, but there are many things that we can do across all healthcare environments. So chronic disease management can then be needs-based, patient-centered, locally delivered, holistic, realistic, almost immediate, and patient-owned. That's the most important part of this. The patient can own their healthcare and deal with it as they see most importantly. So that leads me to the question to you of, is there an argument for a routine 6-monthly face-to-face appointment that takes up 0.08% of a patient's life? It's such a good idea that Amazon have taken it into one of their shows. And I just want to play you this. It's a bit of a laugh, really, but
You may be asking too much of the system here.
Really?
I can just see your link. Is it?
Oh, okay. I will do something else here, and I will
share a different bit of your screen.
Yes, that one. Let's have a look at that. You see that now?
Yes, we can see that now. Yeah, you'll need to go back and. Unfortunately, we can't hear any sound, Chris, but I'm sure it's very entertaining.
Fine. Well, there you go. You can follow it and have a look at it. That's a pity. It's a terrible program that you should never watch, but it's great. Can you see that now?
Yeah. Do you want to change back to your presentation, and then we can?
Yeah. Okay, and we can
get on Alison bit, and then we can move on to us.
Yeah, move on to Alison. So the last thing I had to say was this: that the point of this is that one of our purposes in delivering healthcare is that we should look to try and decrease our patients' dependency on our healthcare system by improving their interdependence in community life. And I think that is something that this model would suggest is the way forward. So I'm going to hand over to Alison now.
Thanks, Chris. If you could just move the presentation forward for me.
Yeah, there we are.
Okay, so just building on what Chris is talking about, I just wanted to give you some of the operational practicalities here. So the slide just there was talking about the transactional side of things. So sometimes when we're thinking about long-term care, chronic disease management, we assume that that means seeing people in the clinic in the old way. But actually, what COVID's taught us, a lot of people like some of the transactional things to be done without them having to attend. So I'm talking about looking your results up online, getting your medication automatically from the pharmacy, using self-management, using email, e-consult, these sort of things. And actually, we've found a lot of people have a lot of benefits from doing that. And then you're moving to sort of relational long-term care. And I'm seeing in the chat here, somebody's asking about why aren't we using near me rather than diabetes clinics? And absolutely we are. But we are also thinking about how we develop that long-term relationship with people as we have in general practice, and we don't want to lose that. That may not be seeing people in practices, but it might be, and some people do appreciate that, being able to attend in person. So we need to think of all the options, and as I say, keep things centred around the patient. If we look at the next slide, Chris, thinking about realistic medicine. So before COVID, the major driver for change in the NHS, what we're all supposed to be doing is looking towards realistic medicine. So I don't know what's going to happen with the chief medical officers obviously left, but we've still got realistic medicine. And how do we do this in a COVID world? So personalised care, change to style to shared decision making, that is still just as relevant as it always has been. And if we move on to the next slide, Chris. So looking at how we would do this in general practice, we still have the health protection advice, thing that hasn't changed, that primary care should make every effort to be triaging all patients, to avoid the patient presenting at the practice or a department unnecessarily, and to minimise any contact with patients with respiratory symptoms. So we're still working in a world where we don't actually see people face to face unless absolutely necessary. However, when you look at it, the probability of symptoms, if you have symptoms of a cough, cold, whatever, of it being due to COVID is low. So people with these symptoms could have potentially lung cancer, other problems. We do need to find a way of balancing that risk for that individual. Is likely that you should be seeing them, and we need to see people safely in practice. So we have guidance on how to see people safely, which includes triaging, so only necessary visits, but also PPE, social distancing, and the usual measures. So really important we still stick with that in general practice. But when you're considering the benefits for a patient, rather than delaying and ending up with a hospital admission due to not being seen, it is often worth now restarting, getting back to chronic disease monitoring for people. And we need hot rooms and cold rooms to protect shielded patients for, although unlikely they would contract COVID, it is very dangerous for them if they do so. Moving on, so the considerations, we can't simply restart, but we're working as clusters. Clusters are finding new ways to do things together, to spread out the shared accommodation, the realistic medicine. Who should we be testing and what should we be testing them for? So that is getting away from routine cholesterol, bringing someone to the practice just to check their cholesterol when it isn't going to change your management. Perhaps extending review intervals if someone's older, well-controlled diabetes, not on any medication. We do not need to be seeing them every 3 months for an HbA1c. And really, how should we be reviewing conditions? That could all be changed. And in particular for me, what do we stop doing? What is too risky or too dangerous or too inconvenient now that actually for the marginal benefit it once had, we're not going to be doing it? And lastly, just to highlight that keep calm, there's no right or wrong answers as to how general practice is going to be restarting their business. But if you look at the principles of patient-centred choice and making sure that you have got all the social distancing PPE in place and only attending when necessary, then hopefully you'll be on the right track. And just to highlight any questions, we've got the primary care COVID news email that you can get from the COVID newsletter that comes out, and we're happy to support any questions practices have about restarting. So thank you.
Thanks very much to both of you. We'll waste no time with any of my chat, and we'll just move on to the main event here. I'm very pleased to introduce 3 of our students. First up is Usman Khan, second is Sara El-Solh, and finishing off is Oki Olukayode, who are all medical students here in Tayside. And they are going to speak about decolonization in medicine and the effects of race through the history of medicine, and how medicine is still affected by racism in a systematic way. Like I say, I'm very grateful for them volunteering to do this. And if Usman can share his screen and his slides and unmute, then we'll get going.
Yep, I'll do that now. Cool. Okay.
Just start the presentation.
Yep.
That's great. I can see everything.
Okay.
Thanks very much.
No problem. So yeah, as Dr. Fardin kind of introduced, we're going to be looking at decolonizing the medical curriculum, and really what we mean by that is looking at how race has shaped contemporary medicine and healthcare, and how then we can address this and then look to fix it. So to give you sort of a brief outline of how this talk will go, I'll be looking at a historical view of how the history of contemporary medicine has shaped it to where we are now. And then we'll move on to look at contemporary medicine and its issues with race and how that impacts patients, and then afterwards how it impacts the healthcare professionals. So yeah, I'll be starting with the history. And just before I begin, I do want to put in a quick trigger warning that there will be some slightly graphic historical details, so just to warn people about that. So yeah, I'm going to be really focusing on the history behind systemic racism that we find within medicine. And I really want to bring attention to this, especially because it's something that really I feel, and we as speakers feel, tends to actually be quite largely ignored. And if not deliberately, it's just something we actually remain unaware of. And as this quote essentially says, that unless we know where we come from, we cannot shape where we're headed. Now, it's going to be a bit impractical and completely disingenuous if I try to provide a complete historical analysis of the sort of racial history of medicine within this short framework. So instead, what I want to do is focus on one particular example and use that as a kind of a story to allude to what I'm trying to say. So the example I'm going to be using is a doctor who probably many of us have heard of, called Dr. J. Marion Sims, who is quite often referred to as the father of modern gynecology. And he was a mid-19th century surgeon who is in particular credited with pioneering surgical repairs of vesicovaginal fistulas, the creation of the Sims vaginal speculum, and new methods of performing gynecological exams. Now, the reason that I've chosen to pick Dr. Sims, as well as him being quite a prominent and well-known example, is that during the years in which he made these discoveries, he was practicing in Alabama, a state in the South of America, where the evils of slavery were very much still rampant. And so what this meant was that for his experiments and the discoveries that he made, he was using living Black female slaves, completely without their consent, as they were Black at the time. They were then viewed as a sort of racially inferior, and so they had no rights of self-autonomy. And I do, encourage everyone to look into the life of Sims, Dr. Sims further. But I'm not going to go into too much detail, but I will quickly kind of provide a brief outline of how he made these discoveries and the sort of character we're dealing with here, just so we can kind of understand the person and how this history has led to where we are. So Dr. Sims practiced on a total of 7 women with no anesthetic, and many of them had to undergo repeat operations. And at the time of the experiments, he would do them. There'd be a whole group of other doctors around watching, completely stripping these women who were already suffering and in pain, any sort of dignity that they may have. And within the literature itself, it's noted that a woman named Anasha was in fact operated on 30 times. Now, it wasn't just vesicovaginal fistulas that Sims tried to experiment and conduct studies on. He was also particularly interested in neonatal tetanus. And Esther Chu, who is an associate professor at Oregon University in America, she's noted that he tested the theory on the condition that it arose from the movement of neonatal skulls during protracted births on female slaves, using an awl to pry the skulls, bones of ligaments of infants, into alignment. These experiments were fatal to the infants. So I think that gives kind of an example of the brutality in his methods. Now, naturally so, Dr. Sims has been criticized in more recent times. This paper here that I've got a screenshot of is probably the most example of it. But unfortunately, you think, okay, there's papers, we accept it, we've criticized him. The reason then I say what I say and use Sims is that actually, despite us thinking that, there's still a lot of problems with how we deal with Dr. Sims's history and how we assess his legacy in regards to medicine, even with such criticism of him. And there's 2 ways in particular that I want to quickly look at. So the first is that there's this, what I would really call a whitewashing of history. And these 2 articles here are just 2 of many examples, really, where we have these quite bizarre, to be honest, and really nonsensical attempts to justify his actions and to kind of shed them in a more favorable light, with arguments being put forward that, oh, he was a man of his time, we cannot judge him as such. And in fact, this top article here was written in response to a statue of Dr. Sims that was taken down. And within it, the author argues that without statues of Sims, dialogue ceases, and thus future generations of African-American children will never know that their ancestors were responsible for many of the cures in medicine today. So really, it's this kind of bizarre argument that, oh, if we remove statues, we remove history, which is something we're kind of seeing now with the whole debate about statue removal. But it's very weird that he chooses to focus on African Americans when talking about statues, when nowhere in his article does he say we should build statues for the women who are actually experimented on. And the second article here kind of says the same thing and essentially says that Sims was a dedicated and conscientious doctor, and because his method can be justified because it brought about a beneficial end. So, you know, whatever he had to do, it's almost acceptable because of what it created. Now, I will return to these momentarily, but the other kind of way that Sims's legacy is dealt with very dangerously is that we just frankly ignore it. Even if not deliberately, it's not something that's taught as part of the medical curriculum. It's not something that's really spoken about. And to kind of find out this history, it's something you would have to go out your way to even find out about. So it's not really something that we openly talk about or we address. Now, the reason this is a problem and the reason those papers are a problem is not necessarily because of what, say, the papers explicitly say, although they are problematic. It's more that by trying to justify his actions or just completely turning a blind eye to them, what we are essentially reinforcing is the idea that Sims and others like had at the time, that the suffering of these black women don't matter because it's just completely ignored or tried to be justified. And just as they were back then, they continue to be viewed as commodities, and whose, you know, sacrifice is a necessary process of progression. And so, yeah, it really renders that pain and misery meaningless and completely silences that out. Because at the end of the day, whether they at the time saw Dr. Sims as unethical or not, we know that it is, and we need to start recognizing that and speaking about that. And just as in the same way, any discoveries that were made by any Nazi scientists or doctors, whilst we recognize any benefits, we do not even remotely try to glorify or honor the scientists or doctors involved, because we don't ever want that sort of ideology to gain any sort of credence or any sort of acceptance. We need to do the same to all aspects of medical history. Now, I just want to sort of, as a little side note, raise the fact that this isn't just a one-off example. This isn't just sort of a dark moment of history. This is very intertwined with much of contemporary medicine. And the two examples that I've brought up here are, you know, this sort of the racial element to do with the treatment of polio, and how once it was considered a white disease, that's when a lot of research and emphasis was put into trying to find a cure. And then also the particularly brutal Tuskegee experiments and studies that some people may have heard of, that actually went all the way up until the 1970s. So this isn't even something we're talking about a long time ago, in which black men were deliberately infected with syphilis, and then they were just kind of left just to study the long-term impact of it. And this has created a huge amount of distrust within many communities towards vaccines, which is, you know, something that really deserves its own talk. But it's just an important thing to sort of highlight. And I would really encourage people to look into these further. So why do I raise this, and sort of to summarize why this is all important, is that it's not that, you know, we want to say rob Dr. Sims of credit or say that, oh, what he did, it hasn't brought benefit now, because undeniably he did pioneer research that has had a big impact on women's health. So it's not a rejection of the benefits in particular, but it's more to remind ourselves that medicine doesn't exist in a vacuum. It's not this field of inquiry that is sort of separate from society and free of its ills or prejudice. It's very much a part of society. It's very much intertwined with society, and it is really a human endeavor in trying to improve our lives through healthcare. And as such, it does fall prey to the same prejudices and racial biases that contemporary society as a whole does. So if we try to deny, justify, or ignore the racist blueprint that much of contemporary medicine has been built upon as contemporary society, what we are doing is allowing these racial injustices on an implicit level to continue, because we act like there's nothing wrong and we put on a metaphorical blindfold, as it were. Now, this has very, very real consequences, and that's something Oki and Sarah will go into in great detail. But one thing I do want to raise, which is very prevalent, especially given the sort of COVID pandemic, is during the peak of the lockdown, there was an interview with a group of French doctors, and this went viral. You can find the videos on YouTube, in which they suggested very nonchalantly, very casually, oh, any potential vaccine for COVID-19 should be tested in Africa, as though Africa is this giant monolith of human guinea pigs whose suffering doesn't really matter, whose lives are inconsequential. So what does it matter? Now, of course, these actions are abhorrent, and the World Health Organization came out and rejected them and condemned it, and why we should. But we need to understand that, you know, these comments, again, they don't exist in a vacuum, and whilst they are a product of personal prejudice, they are born out of a system, and that system is based on a long and quite dark history of racial oppression and experimentation on non-white peoples, whether vaccines, whether surgeries. And I think until we address that, we are going to struggle to deal with any issues in contemporary society, because, like the quote said at the beginning, we need to understand where we've come from in order to know where we're going. So yeah, that was really it from me. I think Sarah's next now.
Okay, thanks very much, Usman. There just needs to be a change around of who's sharing whose screen, and I think that Sara is next. One question that somebody asked me over email since I sent out the reminder was the title of the presentation, which is, as you can see on the screen, Decolonizing Medicine. And I was asked whether actually I'd made a typo and I meant decolonialization. Now, I think Sarah is going to broach the topic of the nomenclature and the deliberate use of the term decolonizing that I think Usman has already just touched on. But Sarah, are you ready to go?
Yes, I am. Thank you.
So if you just start your presentation, we can see your screen, and I'll leave you to it.
Okay, oh wait, hang on. Okay, perfect. So following on from those excellent points that Usman made, I'm going to be talking a little bit about how this history continues to have an impact on the healthcare system today and what effect it's having on our patients. Before we start, it's a bit of a tangent, but I'm going to talk about some definitions. There we go. I think it's quite useful to know what all these words mean before we proceed. So decolonizing is a word that can throw people off a little bit, especially if you're from outside the social sciences. It sounds kind of daunting. Actually, all it means is the process of decentering European knowledge production and prioritizing views that exist from outside this paradigm. So the word is decolonizing. And that's all it means. It means decentering European knowledge production and prioritizing views that exist outside of this very Eurocentric paradigm that we're so used to learning from. The other term I want to talk about is BAME, or BAME. It's a horrible acronym. It means Black, Asian and Minority Ethnic. It's specific to a British context, and it refers to non-white people, and actually some white people considered minorities, such as Irish travellers. It was created by the state, and it has connotations of control, surveillance, tick boxes. I think most people I know don't really like it. Nobody I know identifies as BAME. I know I don't identify as BAME, but I think, you know, we use it and it's there for better or for worse, but it's important to understand that it's a term that was created by the state. And whereas people of colour, in opposition to that, people of colour was actually created originally as women of colour. It was conceived by women activists as a very wide racial and ethnic category, but also, and importantly, as a political category. People of colour is a category that is used by activists to organise for social change. And the goal of creating this category, women of colour and then also people of colour, is to highlight the way racism in white majority countries and imperialism in the global south are connected. So that's the origin of that term. It's also important to note with both these terms that they're not homogenous. The white supremacist world order in which we live was envisioned by colonizing Europeans concurrent with their scientifically racist worldview. So this worldview held, white Europeans at the top and Black Africans at the bottom and everyone else in between. And that hierarchy is still very much visible. When you look at these terms, and also when you look at the way these terms talk about things like, for example, the effects of the COVID pandemic. We had the COVID BAME report that highlighted that, yes, COVID seems to be affecting most BME groups worse than the white community, but the people who seem to be worse affected within this BME category are Black people. I think there was some variation. I think in certain parts of the UK, the Bangladeshi community seemed to be the worst affected. But in general, when talking about these groupings of people, the people who are suffering the worst structural violence are usually Black people, and that's concurrent with this worldview that was sort of propagated across the world with colonialism. The last definition I want to talk about, because we can't really discuss it unless you know what we're talking about, racism. Racism does not refer just to prejudice or bias. It refers to social structures of white supremacy upon which these biases are upheld. That's really important to understand. A lot of people misunderstand this. Racism is not just someone being mean to you. Racism is the social structures that allow that person to be mean to you and to then get away with it. And it covers a whole host of social structures, and it's important to understand that when talking about racism. So moving on to what I'm actually meant to be talking about. What do we mean when we say healthcare is racist? I've split the answer to this question into two kind of groups. The first one is that the medical curriculum and medical institution is racist, and the second part of the answer is that society is racist, and we don't discuss this enough in medical school. So talking about the first part, I think this is kind of the most obvious part. It's pretty clear that within medical textbooks and within teaching in general, there's little recognition of the ways in which patients who are not white, and particularly those who are darker skinned, present with diseases. This is most obvious in dermatology, and I think it's quite obvious what effect this is having on our patients. Diseases are picked up at later stages, potentially with more serious morbidity. And I think we can all agree this is something that urgently needs to be corrected and really should not still be happening in this day and age. It is shocking that it's taken this long for us to take a good hard look at the way we teach and who we are talking about when we talk about our patients. And as a follow-on from this, I want to quickly discuss the Fitzpatrick scale. I wasn't sure I was going to talk about it, but once I started researching, I realized that I had to because it's quite striking. We were taught the Fitzpatrick scale in dermatology. To Dundee's credit, we didn't really dwell on it. But I think the Fitzpatrick scale is a really concise illustration of how Eurocentric medicine really is. There also seems to be little agreement as to what the types actually mean, as you can see by these three that I have copied into this slide. I think officially there should be 6. Why on one of these there is only 5 is anyone's guess. But I think when you look at the all 3 of them, the first 3 are essentially white skin types or very light skinned people of color. And when you consider how small Europe is and how big the rest of the world out with Europe is, and the fact that Europe is taking up a whole half of that scale, and it sounds very much like the anthropologist I am when I say this, but I think you can really see the white gaze when you look at the Fitzpatrick scale. It's very clear that this whole thing was set up through European eyes. When you look at the top left one, it's got Pakistani / Indian / African all in one type. I mean, that's absurd. That's a huge chunk of the world that's just kind of been reduced into this one dark end of the scale. And on the top right hand one, it goes straight from dark brown / Middle Eastern skin types to black, as if both of those things are sort of these neat packages that you can there's huge variation within both of those. So I think it's really that's a really good illustration to me of the Eurocentric way we are taught a lot of things within medicine is the Fitzpatrick scale. So moving on to the second part of the answer, which is a little bit more complex. but very important. I think it's tempting to say that we can sort of solve racism in medicine by adding representations of darker skin tones to our textbooks and our lectures. This is not true, although it's obviously extremely important to add these things, and it's long past the date when it should have happened. I don't think that this is where that stops. It's where it starts. So I think that's very, very important thing to note, that this is not the end of the problem, it's the beginning of the problem, and it's a very good place to start, but there's a lot more to talk about and a lot more to do. So one thing I want to talk about is that within medicine there's very little recognition of the concept of structural violence. I can still remember as an undergraduate when I first heard this term, when I first understood it. It's one of those, it was quite a few years ago now, but it's one of those light bulb moments that stays with you, because in the moment that I understood structural violence, I felt like I understood so much more about the world around me. So many things made so much sense. When I finally understood the concept of structural violence, it was this like big revelation of like, wow, now I can name this and understand it. And I think it's a shame not only that patients are being robbed of physicians who properly understand this concept, but that medical students are being robbed of the opportunity to understand it, because it is not taught in a comprehensive way. As a quick sort of summary of what structural violence is, for anyone who's unfamiliar with the term, structural violence is a concept that was first put forward by sociologist Johan Galtung, and it describes any social force that harms people and prevents them from reaching their full mental and physical potential. Now, when you hear that definition, it really seems like medicine should be teaching this concept more. It's kind of surprising, because actually structural violence is probably the number one cause globally of morbidity and mortality. And it's a very, very complex one. It's a hard one to compartmentalize. Racism is a huge part of it, but so are other social forces. And I think that's another thing that structural violence really highlights, that you can tackle racism. It's very important to tackle racism, and that's what we're talking about mainly today. But there is no racial analysis without gender analysis, and there is no gender analysis without class analysis. We have to analyze all these things together in order to really tackle them. And structural violence is a really great framework from which to start those discussions. And this is a really good sort of image representing structural violence. And medical education tends to shy away from politics. It's something that I've definitely noticed, and it's something that Usman and Oki have also noticed. We talked about it when we were setting up this presentation. And I think a really good example of the way medicine shies away from talking about politics, which isn't directly related to race, but it's relevant to the discussion, is in first year, we had a tutorial about a cystic fibrosis drug called Orkambi, which at the time I think wasn't licensed for use on the NHS because it's quite expensive. I think it has since been licensed. But we were given this tutorial, and it was a great tutorial, and we were taught about how expensive this drug is, and we were given this kind of scenario where it was, well, we can give 50 little old ladies hip replacements, or we can give one child Orkambi for a year. All very important, and the tutorial was really well set up. It was set up with the trolley problem as well, which is also like a really good thing to teach people. And we live in a world where there are finite resources. These are decisions we have to make. But the thing that really surprised me in that tutorial was there was absolutely no discussion of the fact that these numbers are not handed down from God herself. Like, they don't just exist in the sky, and people are making decisions about the resources we can allocate to our patients. And to me, if you don't talk about that, you're only talking about half the problem. And I think that's really representative of the way medicine just kind of skirts around problems sometimes that people just don't want to discuss. And that happens a lot with racism. And I think it's to the detriment of patients and doctors of colour. A lot of us, Oki will talk more about this later, but a lot of us don't feel as safe in the workplace or in university as we should. We don't address implicit bias head on, which is really the only way that you can address it. And we see this reflected in the fact that, for example, there was a study in the Journal of Pre-Hospital Emergency Care that showed that Black patients with painful injuries like fractures and burns were less likely to receive pre-hospital pain management. that's a serious thing that we need to address. And the reason this is happening is because we aren't addressing things like implicit bias, things like the history of medicine, things like structural violence within the curriculum properly. Another study in the New England Journal of Medicine showed that ethnic minority patients with metastatic cancer were 3 times less likely to receive appropriate pain management. So yeah, again, that's something that really needs to be addressed, and it's an important negative outcome of all of this that affects our patients every day. I'm going to hand over to Oki now.
Okay, Sara, thanks very much indeed. I should just perhaps point out to you that Sara did a previous undergraduate degree in medical anthropology. That's right, Sara?
Yeah.
Just to give some context to her comments. Now, finishing off, as we just swap slides around, is Oki Olukayode, who's going to finish off by talking about racism and its impact on the workforce. Okay, you there?
Yes, I am there. Can you hear me?
We can. Thank you very much.
Awesome. Just a little side note. I'm currently in the middle of a house move, so I'm currently using my phone for data. So if I cut out, you can't hear me, please just let me know if you can't hear anything. So I'm talking about racism and its impact on the workforce. So the week before George Floyd was murdered in the US, I organized a webinar, an informal webinar for the other Black medical students at the University of Dundee. And I invited a Black doctor I know from London to talk to us via Zoom. And I sent out a form and asked the rest of my colleagues to send in questions beforehand, so that way the doctor from London can prepare for their questions. The webinar was designed to be a sort of careers talk and stuff that we should really look out for in medical schools to make the most of opportunities. However, the questions we received were a bit concerning. So I made a word cloud. Of the different words that came up repeatedly in the questions that were asked. So if you guys know anything about word clouds, the words that are really big are the words that came up a lot. So our colleagues, Black medical students, the thing that is constantly on our mind is, are we going to be singled out when we're at work? Are we going to face microaggressions? One of the questions was literally, is the NHS racist? Or how do you report if something racist happens to you? So Black students, not only are they having to deal with the intensity of the medical course, or intensity of a medical degree, we are also having to think, how am I actually going to survive and be safe in the work environment? Recently, the BMA released a racial harassment charter for medical schools. And these are the charter is grouped into 4 different areas. So which is supporting individuals to speak out, ensuring robust processes for reporting and handling complaints, mainstreaming equality, diversity, and inclusion, and addressing racial harassment on workplace placements. So as you can see, lots of different universities and medical schools have signed up for it, including our own medical school, which is amazing. But what does it actually mean for us? I'm going to be focusing on mainstreaming equality, diversity, and inclusion across the learning environment. And I'm focusing on that because I think that is the most relevant aspect to what we are discussing today. So as Sara has already described earlier, when we think of racism and think of someone who's racist, we have this idea in our head of like Mick down the pub, who is a member of the English Defence League, and he yells racist abuse at you. But unfortunately, Black people and other people of color, we're not exactly waiting around to be called the N-word before we say something racist is going on. So I'm going to go through 2 case studies that illustrates the other subtle ways racism can come through. So this is a real lecture slide that I sat through recently. So it's talking about the racial differences in terms of IQ. And again, as Sara has described earlier, It's very, very much centered around whiteness. So European students, European people are the average of 100, and everything else is a deviation from that European norm. And an Asian or Jewish person might look, or you might look at this information and think, oh, that's great for Asian and Jewish students, but what does that actually mean for them? So what that means is there's this assumption that Asian students and Jewish students are already really clever. So when they do actually need help, people aren't noticing because of this implicit bias that you believe that, oh, the IQs are really high, and so they're fine. And then in terms of Black students, as you can see, the average IQ of sub-Saharan Africa is between 67 to 82. And for African Americans, it's 85. And in brackets, you can see it's catching up. But what does this mean for Black students? I can't really speak for every single Black students, but I can speak about my own personal experiences right from school. My story is one of my abilities constantly being questioned at each individual stage. Just even thinking as far back as just applying to university in the first place. Throughout my school career, I'd only ever got one B ever in my entire school career, and my head of sixth form did not think I was capable enough of getting 3 A's at A level, even though the lowest grade I've ever gotten was a B. Now, it may you might think, oh, maybe he had like specific reasons for why he chose to make that decision, but I think you can't argue with the evidence in front of you where no matter how well you're doing, there's always like this implicit bias that maybe you're not actually that clever, or maybe you're not that actually able. The second, and I want to talk a little bit more about scientific racism. So this is like one I've always found really interesting. So I'm a huge fan of athletics, and people always say, oh, the 100 meters final is always full of Black people because Black people are so much more muscular and they always win the 100 meters. But we also hear that Black people are also better suited for long distance running. So the question I have to ask is, which one is it? Like, from my knowledge of athletics, in terms of like biomechanics and like muscle distribution, long distance running and sprinting require completely different biomechanics. So to just group all Black, to attempt to group all Black people to say that they are all muscular just doesn't completely make sense. In West Africa alone, there is more genetic variety than in all of Europe, and in the whole continent of Africa, there's more genetic diversity than in the rest of the world put together. So when we make sweeping comments about genetics and Black people, it just simply does not make sense. So this is my second case study. So this is a real event, and however, this is a fake picture. A couple of years ago, I decided to join the Medics Review at the university. And on the final number of the show was a slideshow of lots of students just having fun, doing their thing. And on one of the slides was a medical student in blackface. We are in 2020, and I think we all know that blackface is something that's not acceptable at all. But then to make things worse, on the slide after that medical student in blackface was a picture of me. So I had reported this to the other show's director and asked and said, this is really awkward. I don't know if this was on purpose, if this wasn't on purpose, but this is not acceptable at all. However, the issue wasn't addressed full stop. And I was left to feel really awkward throughout the entire show and the rest of the show's run. And I thought about reporting it to the medical school, but I didn't want that reputation of being that person who complains a lot, who complains about things not going right. And yeah. And this is kind of illustrated during like the election campaign when Black Labour MP said Boris Johnson is racist, and the other white female MP was flabbergasted by her saying this and was really annoyed at her for even implying that Boris Johnson could be racist. He's said things that are objectively racist, compared Muslim women to letterboxes, called black people pickaninnies with watermelon smiles. And we live in a society where it's more offensive to call something racist. It's more offensive to be accused of racism than the actual racism in itself. Last year, around this time last year, the GMC released a report called Fair to Repair, and it's discussing the how our BAME colleagues are more likely to be reported to the GMC in terms of fitness to practice concerns. And the key findings are the blame culture within the NHS, members of in-groups receiving favorable treatments, and lack of effective, honest, or timely feedback, because some managers would rather avoid difficult conversations. And I'm just going to focus a little bit more on members of the in-groups. Unfortunately, race is one of those things that allows you to become a member of an in-group more easily, or doesn't allow you to become a member of that in-group at all. I have stories of friends who are doctors, who are black doctors in other cities, like Manchester, who've reported that, well, whilst they've been preparing for postgraduate exams, their bosses have helped their white colleagues with private tutorials, but they've been left out of those tutorials. And this is something that is prevalent across the entire UK. And the recommendations that the Fair to Refer reports made was that we need to address systemic issues that prevent a focus on learning rather than blame when something goes wrong. We need to ensure that everyone's engaged, and ensuring that engaged, positive, inclusive leadership is more consistent across the NHS. And we need to think of how this can be developed into a UK-wide mechanism to ensure delivery of recommendations. So I'm going to finish with this quote by Toni Morrison. She says the very serious function of racism is distraction. It keeps you from doing your work. It keeps you from explaining over and over again your reason for being. And I'm going to finish on this word cloud from the webinar that I did for the Black medical students at Dundee. So rather than us focusing on our studies, rather than us focusing on how best we can function in a really difficult career, we are more concerned about, am I going to feel safe? Am I going to feel singled out? Am I going to have to face repeated microaggressions? So to conclude on everything we've spoken about, science does not exist in a vacuum, and healthcare professionals are part of society. The racism that is prevalent in society is also prevalent within the medical field as well. And as healthcare professionals, we need to realize that and take ownership of that, so that way we can make good progress. And also, medicine needs to integrate a more biosocial perspective when dealing with conditions. It's not good enough to just say, yes, Black people in general get these diseases. We need to find out why. Race is not a biological construct. It's not biological at all. It's a social construct with real life consequences. So rather than focusing so much on the biology of the different diseases and how it affects different groups, we need to focus a lot more on the social aspects as well. And that's it.
Okay, thank you so much for tying that all together so well. To all three of the speakers, I just thank you so much for putting the time into giving that presentation. There are, as you can no doubt see in the chat, a number of people complimenting you on the presentations, and I add my voice to that. I have had one question sent to me, which to put to Sara, if possible, if she can reappear on the microphone. The question is, I just wanted to ask Sara that racism has become an inherent part of Western politics and Western systems. So do you think we can tackle racism in healthcare when it is inherent in British culture, politics, education, etc. As the question writer has written, as someone of colour myself, who has very much felt this from colleagues more than patients, I believe it's a vital thing to address. Perhaps do you have a comment in response to that, Sarah? Or
yeah,
any more speakers?
Yeah, does anyone else want to weigh in, guys? I mean, that's a big question. I think that probably addressing that starts with addressing the fact that medicine is a part of society and not as a large part of the medical community likes to think, sort of a separate apolitical, ahistorical bubble. So I would say maybe that's a good place to start. We need to accept that as doctors we're part, or medical students we're a part of society, and we do reproduce biases, and we do need to, and we reproduce them with worse consequences as well, you know, for healthcare providers. And I think she's talking about workplace, like racism in the workplace as well. And I think probably, I mean, I haven't worked for the NHS yet, but I have heard an awful lot of things that are quite scary for someone who's not white, about you know, just casual racism, and I think addressing that is a big a big problem. I don't know if guys, someone else wants to weigh in, that'd be fantastic. Anyone else want to weigh in on how we address
I think, as you say, Sarah, that's a very big question. I think you've answered that very eloquently. There is a question for Oki, if Oki's still there. The question is, regarding more Black people dying during the coronavirus pandemic, why do you think this has happened? The questions get no easier, I'm afraid.
I think it's a complex issue. So I think I feel like it's very easy to say, oh, it's due to like some sort of genetic issue or something, which might be the case. But I think more concerning is a disproportionate number of Black people work in the essential services. So they work as cleaners, they work as the bus drivers. Like we've heard the story of the lady who was working at Victoria Station who got spat at by a passenger, and that's how she caught the coronavirus and eventually passed away. So this is what I mean by where we need to look at the social aspects of the disease as well. I'm from London, and a lot of Black people I know in London also work in care homes as well. So I think Black people, part of the reason Black people are disproportionately affected is because they're disproportionately found in the areas where it's, I guess, easier, more susceptible to catching coronavirus as well.
Okay, and I think you raised from a coronavirus frontline point of view, I think you raised very valid points there, and I'm from Yorkshire originally, which has a more diverse population, but mainly from a Pakistani and Bangladeshi population rather than a Black population in West Yorkshire. And my friends and colleagues back in Yorkshire have very similar comments, that the Pakistani population do fulfill a lot of the roles that you've described in cleaning and healthcare and bus driving and taxi driving, things that are very high risk. And just echoing back on what I think it was Sarah said, the delay in providing care and analgesia for people who have burns and wounds, I think that's a worrying thing if that's being propagated in terms of COVID. Does anybody else have any questions or comments they'd like to make before I sign off? Right, well, I'd just like to finish then, say fantastic presentations from all three of our medical students. I think if I think back to when I was a second year medical student, I would have been somewhat intimidated to present to the entirety of the Grand Round audience, and you've done it with great aplomb. Hang on a second, just as I finish off, Rory McCrimmon, who is the Dean of the Medical School, has just said he'd like to just perhaps make a comment about the changes that the medical school is making in terms of the curriculum. So Rory, I'll just hand over to you and then we'll finish. Can you unmute and
Yeah, Tom, can you hear me now, Tom?
Yes, we can hear you now, that's great.
I'm not going to talk necessarily about the changes to curriculum. What I was going to say to Oki and Sara and Usman is obviously that we're very grateful for the presentation they've given to the school. I think it's really useful information that they've all written to me independently, and we're going to catch up and with Ellie, and we'll talk about how we might integrate more into the curriculum. I entirely agree with you that medicine has worked within a sort of biological reductionist model for probably far too long, and science needs to recognize that it is part of our culture, and the medical school is part of our culture, and we need to see our work in a much more closer context. It's a little bit like the pathways that we looked at, the care pathways earlier in diabetes, where, for example, the major determinant of outcome is actually your health equality state, your socioeconomic status, and not a biological model. And we just need to be thinking much, much more about how we are working within that context more broadly in society. So I think we'll work with our students, and we will try and develop this program much more so than we have done in the past, to look at implicit bias and these other concerns that they've quite rightly raised.
Thanks very much, Rory. So I'll draw things to a close. Thank you, our speakers again. I thank you for coming along, and hopefully I'll see you again next week. Thanks very much.
Thank you.